everyone. My name is Rebecca. I am one of the co-chairs of the GMA SAEM Humanitarian Committee with Vinay Kampala. This is a really exciting webinar today because Dr. Mwafi is one of my mentors. He helped me when I was just kind of starting in global emergency medicine. And I really wanted him to be able to talk to you all because I thought that he has just so many insights to share on how to go about humanitarian research, which is just such a different field that I think it's really important for those who are getting started to hear from others about their experiences. So Dr. Hani Muwafi is an associate professor, chief of the section of global health in the Department of Emergency Medicine. And he also serves as the director of the Global EM Fellowship. So keep that in mind if you're looking. And he focuses on developing the science and practice of emergency care with emphasis on low and middle income countries. He's done a lot of work with humanitarian interventions and research in Syria. And then Danielle Poole is going to be joining him, which we're really excited about, as an epidemiologist and geospatial health researcher and director of the health research with Yale Humanitarian Research Lab. Has a lot of experience conducting humanitarian health research with her work centered around measuring needs among populations affected by crisis with a focus on health during displacement and novel research methods. So the perfect people to give this talk. So with that, I'm going to turn it over to them.
Thank you for the very generous invitation, first of all, and introduction, Rebecca. So there's a long list of names here. Some of you I recognize as real experts already in the field of humanitarian health, and others of you I haven't met, but I've seen your names in different fora. So we're excited to come make this presentation, but we're also hoping to kind of make the presentation a little bit interactive. So understanding that not everybody is going to be in a position to turn on their camera or to chime in, but we're hoping that some of you will, use the chat, raise your hand, and we can stop. We're not going to reveal any galactic secrets here in this talk. I think the discussion can actually be really, really fruitful. So with that, let me start. So we're going to talk a little bit about challenges of health research in humanitarian settings, and just the concept of doing research in a humanitarian setting, I think, immediately sounds challenging, but it's kind of challenging at every level. But I'd like to start with the first question, which is, why bother, right? In the face of so many challenges, I think people can be forgiven in thinking, why are we spending time, effort, limited security on collecting data when there's obvious need all around us, and we should be spending every penny and every moment trying to address that need. And it's a legitimate question. It's one that most policymakers are going to have. It's what many funders are going to have. And I think the answer is that there's a domino effect of humanitarian crises on all of health, right? So if you don't actually understand what's happening during a humanitarian crisis, the communities that are involved, the primary health problems that are presenting, and what the effect is on the health system itself, then you will miss the coming calamity that is represented by all of these other elements of health becoming impacted. We know that there's some overlap between different types of crises. So this image shows climate-related hazards, displacement, and conflict. And you can see that there's a whole lot of overlap, specifically in the areas of conflict and displacement, but you can also see these areas that have the most extreme climate risk throughout South America and Central Africa are also affected by these various humanitarian crises. And we know that it's affecting more and more people each year, right? So this graph shows IDPs, people that are displaced as refugees, asylum seekers, et cetera. And we see that every category is growing year over year up until the most recent year of data that we have. And as in any health problem, when we have a phenomenon that's affecting a large number of people at a global scale, right, we need evidence to make decisions. We're talking about massive investments in resources and time to these problems, so we should actually know what we're doing. Now, this paper was published a little bit ago in The Lancet 2017, but it was looking at the degree of evidence that we have for various public health interventions in humanitarian crises. So even if we're just looking at the research you need to determine your operational next best steps, we don't have excellent evidence, right? So for communicable diseases, we have pretty good evidence, as you can see, and injury and rehabilitation is maybe the lowest quality evidence according to the authors of this publication. So there's a range in between, depending on which domain you're looking at. So there's clearly lots of opportunity for quality improvement in terms of the services that we hope to provide. So here's where I would like to ask people some questions. How do you know when you're in a humanitarian crisis? How do we know if we're in a humanitarian crisis? Anybody have an idea? Or what is a humanitarian crisis? So the needs exceed the resources available. Definitely. That is the definition of any crisis, right? But what makes it a humanitarian crisis? So definitely the crisis is the needs outstrip our resources. It also tends to affect large populations, right? So it's not, and there's a threat to human health. Gabriel chimed in. And then, sometimes these crises are as a result of natural disasters, earthquakes, floods, windstorms, and sometimes they're the results of man-made emergencies, such as conflict. And before I do that, do you think there's overlap between these? I showed you a map where there clearly was some overlap, but can you imagine how these play together, the interplay between them? You don't have to turn your camera on if somebody just wants to chime in. That's also so they involve disease, mortality, or death. That's true. All of them can do that. And anybody else? Okay, so another important element is that whatever the impact is of the one, if you remember the domino image that I showed earlier, when it starts to break the health system, right, it starts to break your ability to deal with other health problems. Women who die at home from obstructed labor because there's insecurity and they're unable to get to a trained provider, that is an excess death that, but for the conflict, would not have occurred, right? People who have, their environment flooded and become more prone to waterborne illness, these are excess deaths that would not have occurred for this humanitarian crisis. All right, so let's get back to the lecture already in progress, right? So how do we know? I think a characteristic of a lot of these modern crises is that they don't have a defined start and stop, right? Many conflict zones, for example, go from chronic to acute to chronic to acute. Many climate emergencies, we see the interplay of multiple climate effects. So you have drought, which devastates crops, the ability of and vegetation, the ability of the soil to hold water is less. Then you get a rainstorm, which results in massive flooding because there's no vegetation there to help absorb the water into the soil gradually. You get flash floods and all of those problems. We also know that conflicts don't have a defined start and stop. So we are used to reading in history books that the war was declared on this date and it ended on that date. But we know that most wars, including most especially the modern conflicts, don't have start and stop declarations. So we know that Russia invaded Ukraine, entered Ukrainian territory almost a decade before the ramp up of hostilities that we are now looking at today. We know that the conflict in Israel and Palestine has been enduring for decades and waxes and wanes and has different character in whether if you're talking about the West Bank, whether you're talking about Gaza. We know that conflict in Sudan went from a complex inter-ethnic violence that some term genocide in Darfur in the early aughts to a political crisis when the president fell, a longtime president dictator Bashir fell, and you had a civilian council followed by a quasi-stable interim period under military rule, and now the factions within the military are fighting each other and the entire country has descended into civil war. But ultimately, who's most affected by all of these things? It's people. civilian populations, right? And studying the impacts of these events on people is challenging at every phase, right? So it's challenging to come up with the question of what you want to study. And frequently we're trying to study not just the impact on a particular population, but sometimes we're trying to study the delivery of services to mitigate those impacts. It's difficult to plan that research and get funding for it. It's hard to collect the data, to analyze the data, and to disseminate our findings. So we're going to touch on a couple of these things, and then I'm going to hand off to Dr. Poole, who's really going to talk about some of the nuts and bolts of humanitarian research in recent conflicts. So one toolkit that you can use is the Humanitarian Research Toolkit published through IRC, International Rescue Committee. So this is actually still a work in progress, but it's a collaboration with multiple stakeholders that for each one of these phases, right, from your research design to launching your research to implementing your study on the ground, analyzing it, and then facilitating uptake to really learn from what you found in your study. There are several complex processes, and this toolkit is actually one of the more useful toolkits that can help walk you through how to think about different elements. Like we don't have the time to go through all of the pieces here, but it's something that I highly recommend all of you check out. You can find it at rescue.org or Humanitarian Research Toolkit. There's also increasingly the understanding that these are events happening in real time, right? It's not a controlled setting like a randomized controlled trial. It is not historical data that we can pull and do some sort of secondary data analysis. We need to be able to deploy into the field while these events are occurring, not similar to journalists, but with a different purpose. So part of doing so effectively means having research partners, getting your kind of ducks in a row before a crisis happens, and trying to work with specialized IRBs that do understand humanitarian health research, where you can get a provisional protocol and IRB approval in place before an event happens. So for example, if you wanted to study a new way of providing service delivery in a earthquake zone, right? You don't know exactly when the next earthquake is going to happen, obviously, but you can come up with your process, come up with your protocol, and work with an IRB to give you provisional approval, right? That would help you more rapidly get approval to go in the field when the events actually happen. R2HC is another funding mechanism. It's called Research for Health and Humanitarian Crises. That has been around now almost, I believe, a decade or more, where they actually have some flash funding that is available for breaking crises, and they have funding that's available for ongoing crises. And as we have come to understand, there's a long continuum, as I said, this waxing and waning of intensity of natural and man-made disasters. So frequently your study might still be relevant over the 6 months to a year that it takes to secure the funding and get in the field. Now they have the flash funding that's there is dedicated for projects that are very time sensitive and need to be deployed immediately, and having your pre-approved IRB will help you move that timeline much faster. So to get the data in a conflict setting is complicated because it introduces the issue of insecurity. You want to be able to get data that is representative, that isn't just your facility or the facilities that you have access to. But to do so, you frequently have to develop partnerships to overcome the natural reluctance to share. Different organizations supporting different health facilities, for example, have their own funders in mind and may not feel comfortable sharing all of their data. So they do share it with the health cluster, but in terms of conducting research, more than just counting events in the field, you frequently have to develop long-standing institutional partnerships, because you have to overcome the questions of whose data is it and for what purpose is it being used. And this is made all the more complex in the context of ever worsening insecurity, for healthcare workers themselves, humanitarian health workers. We saw the unfortunate rising trend of displaced persons a year over year. Well, this is the rising trend of health worker killings in humanitarian conflicts a year over year. We see 2023 is a huge spike, primarily impacted by these three conflicts in Gaza, Sudan, and Ukraine. But the trend was in existence even prior to that and remains a worrying trend for health workers and humanitarian health researchers alike. Let's say that you do get the data. Humanitarian health data is notoriously messy. You have problems of missing data, you have problems of misattribution, you have problems of delays in reporting. So you see spikes when data suddenly comes in because it all came in on the first of the month, or when it was safe enough to travel, etc. So, and there are various methods that people use to better understand the raw data and to model it. But you always have to be very explicit with the assumptions that are going into your model, because they make the data more presentable, prettier, but you really run the danger of wrong assumptions leading to wrong results. But we have gotten better and better at this over the years, and the understanding that data needs to be shared widely and to be normalized so that it can be compared across settings. So another resource that I'm going to direct all of you to is HumData, a humanitarian data exchange, which collects data from multiple sources and systems, different NGOs for different purposes, and puts them on a shared data platform now. This is an excellent resource, for some raw data. It's an excellent resource for the comparing data collected in different settings, and you can generate different products and graphics for websites. But the most important thing is that they actually have a process for normalizing the data and for ensuring that data is reasonably clean before it's aggregated, so that it can accurately reflect the reality of the work on the ground. It's collected in a systematic fashion, and we know that it's buy-in from people who are real humanitarian health practitioners. So what's the best way to disseminate humanitarian health research? What do you guys think? How do you guys learn about humanitarian health research findings? Going once, going twice, Bueller. Nobody's old enough to remember that reference. So usually after the fact, that's true. So we frequently don't fully understand the impacts of humanitarian health crises in real time. But where else? After it's been picked up by the mainstream media. Okay, that's true. So news reports. How else do you guys hear about humanitarian health crises? So field reports from NGOs. So that's a great resource. Field reports from NGOs, and sometimes the situation reports published by UN agencies. These are excellent sources in real time, but they frequently, and Dr. Poole is going to cover some of these limitations, they frequently don't focus on the same thing for every report, because they are kind of, maybe they want to capture the attention of the media and decision makers, so they frequently are highlighting whatever is the most pressing need at the moment, right? So if we are facing a potential for famine, a situation report might come out with lots of information about famine in this month's report that might not have been consistently reported month after month after month over a long period of time. So it makes it difficult to identify trends. So media reports and NGO reports can sometimes be limited in that way. Where else do you find? For me, the majority from niche conferences and events, right? So sometimes you get it from a community of practice where you meet with people who have similar interests. Somebody said from great literature, sites like the New Humanitarian, but that still caters to a global North audience. So that's true. But you're right, there's more and more venues to access this type of data and the results of the analysis of this data. So a few of you, I'm sure, come across published articles still. But as we learned in COVID, right? So we learned that you can get an article out. If it's a worldwide importance issue, right, you might be able to get your article out in a relatively fast time, right? So this is one of the first articles published in the Lancet about COVID. It officially went into the April 2020 article journal, but it was accepted online at the end of February, which we know was probably 3 or 4 months into the pandemic and after it had been declared by WHO to be a global pandemic. We all got used to the concept of preprints, and a lot more so during COVID, because we recognize that these are events happening in real time and it was important to get information out. So we were still dealing with scientific literature that was analyzed, had not yet been peer reviewed, but the intention was to submit it for peer review. So you hope that it's at least up to a certain standard. And we can see that just in the 3 months from at the beginning of 2020, we had almost 620 articles related to COVID-19. And then, oh, geez, it happened again. So then I apologize for my lack of tech savvy here. I thought that all of that would be properly layered, alas. So what we can see is the use of COVID dashboards. So we got used to putting raw data cleaned and then into dashboards to allow us to quickly visualize trends over time. This doesn't go on your CV as a publication. It's frequently published just on your website, but it can provide some of the most important information about rapidly changing events. I'm going to skip through some of this because I want to jump to Dr. Poole's presentation, but these are some graphics from an article that I'd written about impacts of the Syrian health impacts of the Syrian war, excuse me. And you can see sometimes we're looking to see where events are happening. Sometimes we're looking at the geographic distribution of resources. Sometimes we are trying to document what are the physical injuries suffered by individuals. And sometimes we're really focused on patterns of behavior, right? And this graph shows the number of trauma presentations, and these are weird groupings, right? But because we don't have designations of civilian and combatant in many conflicts, frequently we rely on proxy measures. And in this case, I was relying on the proxy measure of children, women, and elders or older adults. And because of the potential for teenagers to be considered combatants, we also looked at 0 to 12 of all genders, women of all ages, and older adults to see if there was a rising trend over the course of the study during the conflict to see people's impact. And this is percentage of presentations. So you can see if you looked here that we reached between 40 and 50%, depending on your definition of a child, of the impact of 40 to 50% of all trauma presentations were of presumed civilians, right? This has implications for accountability after the fact. So sometimes we focus on supporting actual care provision. Sometimes we're documenting the impact of humanitarian crisis. And sometimes we're trying to figure out kind of patterns for accountability purposes. So with that, I'm going to stop and pass the mic over to Dr. Poole.
Thank you so much, Dr. Moafi, and all. It's such a pleasure to be here with you today. I'm going to pick up on a couple of threads that Dr. Moafi described related to attacks on healthcare, which has been the topic of my research in the last couple of years among the more broad field of humanitarian health. And this topic is, I think, of particular interest to you all, as well as humanitarian research in general, because it's both directly limits or challenges research in these settings, or particularly conflict-affected settings, and is also a great example of different types of challenges that can occur while doing health research in humanitarian settings. I'd love to invite you to feel free to, ask questions at any time. So please don't hesitate, either in the chat or just pop in on audio. So as Dr. Mwafi mentioned, there's a growing trend, a possible growing trend of attacks on healthcare and conflict. Certainly, the way that we've documented it has changed a bit over time, but nonetheless, there's extraordinarily and unacceptable numbers of attacks on healthcare workers, healthcare facilities, and patients. And particularly this last year, there was over 2,500 attacks among medics and health workers in Gaza, Sudan, and Ukraine combined. Those are really the three areas where this has been a matter of pressing concern recently, although certainly not exclusively. The attacks on health have also, beyond the actual workers, have included, of course, direct, morbidity, mortality to patients, and then also just to the health system structure. And so you are, I'm sure, familiar with lots of examples of different militant groups overtaking medical facilities, bombing those facilities, rendering them unusable. And that's been just an increasing trend across several of these conflicts, several of the recent conflicts, as well as over time. Attacks on health are also a challenge in terms of health research. It creates this ecosystem of really lack of information or data. And this is because there's just simply isn't a way to collect data while also addressing immediate needs that are now even more pressing because you don't have the actual human resources and physical tools to provide care. So we often don't have a great understanding of the scope of this problem just because it makes it harder to collect information. It also just really limits our ability to understand what is happening with population health. One example I have, Dr. Mwafi and I have worked on actually together, is that in Gaza right now, there's several field hospitals where they would love to be doing more, the emergency medicine providers would love to be doing some research on the types of injuries they're seeing, but are precluded from doing so largely because they're using paper-based files to collect patient and health information. And there's just not an ability to put infrastructure in place when field hospitals are constantly having to shift because of bombardments. This certainly impedes the operational response in the immediate term, of course, from the lack of care provision to the population, as well as just the planning for healthcare delivery. So again, other examples include vaccine rollout. An example from my work was in Ukraine. It became, especially in Mariupol, which was under siege, essentially, it was besieged for about 6 months in 2022, that the bombardment was so complete that there were very few standing health facilities. And so for the health cluster, that was the UN coordination of the health response in Ukraine, it was really rather difficult to determine where they could send life-saving tools, like the types of machines that are used to treat burn victims, for example, because they did not know if that facility was still standing or not. And then finally, the longer-term challenge of this phenomenon is the lack of accountability. And I'll also say the planning of recovery. So what needs to happen once the conflict ends? What will the health system require? What types of, primary, secondary, tertiary facilities will need to be built, staffed? What kind of training might need to happen if there were attacks on, that were disrupting the medical education, for example? So these are the main ways that attacks on health really affect the ability to obviously provide health as well as to conduct humanitarian health research. And yet, healthcare and the facilities where it's provided are protected under the Geneva Conventions and their additional protocols. And a summary is just to think about the Geneva Conventions, if you're less familiar, as basically the rules of war. So these are rules that combatants are held to. They're meant to protect civilian objects. Medical care, and that's the specific language, is considered a civilian object. Civilian objects are things that are essential for the health and well-being of populations. They also include things like schools, cultural sites, the power structure, civilian homes, things like that. And these rules of war require combatants to, when they're engaging in conflict, to both make a distinction between civilian objects and non-civilian objects or military targets, and then to demonstrate proportionality, which is a principle that is basically suggesting that any military advantage that might be gained from an attack on a civilian object needs to be proportional to the impact it will have on the civilian population. And then finally, should it be of military necessity? And then finally, to follow the principle of precaution, which is that should there be an attack on a protected civilian object, for example, a medical facility, combatants are expected to take precautions which include advanced notification and evacuation. So in the case of medical facilities, you would imagine notification and then the effective evacuation of patients and staff to alternative places for care. So we have these protections, and we have an idea that there's this ongoing problem of attacks on healthcare, which again makes it very challenging to conduct health research in these settings. And I just wanted to highlight a few of the gaps that we have currently on just how big of a problem this is. So the mechanisms that we have for kind of systematically documenting attacks on protected civilian objects can have a sensitivity as low as 1%. That means they're only maybe detecting 1% of events. The two papers cited here are actually, this work has been done among attacks on education in particular, so that's what this specific number comes from. But more broadly, you'll see that as a trend for attacks on healthcare as well. We, in general, have an absence of a standard way of describing an attack on healthcare. The way that attacks on health get categorized varies from data set to data set, which are mostly maintained by large international organizations and then different, more local organizations. But this absence of a standard classification limits us from kind of comparing things both within a conflict over time as well as from one conflict to the next. There's also more and more actual evidence of a privileging of particular forms and locations of incidents. And by this, I mean, there's, the gaze of research that focuses on attacks on healthcare has focused on some very particular conflicts and almost exclusively ignored others. For example, the Tigray and Ethiopia, where attacks on healthcare was a major concern, but was not nearly as publicized as what we have seen in the past year, particularly in Ukraine and Gaza. Another study of some of these large global data sets, including the WHO's surveillance system, which the WHO has undertaken since 2015. It was a mandate of the World Health Assembly of 2012 for the WHO to actually collect and share data of attacks on healthcare, and the overall agreement between that data set and another really large, comprehensive data set documenting events of attacks on healthcare in conflict was only 12.5%. So we are missing a lot. We are most certainly underreporting. And the effect that this could have on the rest of the evidence we have in humanitarian settings is potentially just massive. And then, of course, finally, the actual peer-reviewed literature that uses quantitative data to understand these problems is really lacking, with most of the peer-reviewed literature describing cases or more qualitative descriptions of particular conflicts, which is extremely important and required to understand the context of these patterns, but doesn't often allow us to easily look at things overall and understand what is happening as a pattern of war, of modern war. So our group has been using remote sensing to supplement some of these other data sources. And this is just one potential kind of fix for this challenge, right? So if collecting data in crises is very challenging and it's dangerous, and it can also be dangerous for the people, like your local partners, especially if that's not yourself, then using some remote data collection might help fill some of these gaps and might help overcome some of the challenges to conducting humanitarian health research. So satellite imagery, we have satellites that are orbiting the Earth and generally picking up images about once every 24 hours of the same spots. So you'll see, you can be over Darfur, El Fasher, in Darfur, Sudan, around 1 o'clock every day. There's an image that's getting taken. And this changes a little bit depending on prioritization, whether or not these satellites have been tasked for other specific projects. But all of these images are archived, and Lots of them are available to the public, although often at a fee. If you're interested in this, Maxar does have a humanitarian need platform where you can request images for free for humanitarian purposes, and they will provide them, even the very high resolution images, which is quite cool. And they allow for some standardization in how you assess damage. So really, this is only about exterior damage to buildings. And as all conflicts are carried out in a bit of a different way, the usefulness of this in whatever situation that you're interested in might kind of have some nuances. But satellite imagery analysis has already been used for evidence of alleged war crimes in a number of courts around the world, and looks like it will continue to do so. This is just an example of what that would look like. So this is from our work in Mariupol. We did a census of damage to healthcare facilities in Mariupol during that 6-month besiegement. And on the left, you'll see an image of the Mariupol Maternity Hospital. And this particular incident was widely publicized because it was an operational hospital. So it was fully functioning, full of patients, staff. And then this was March 14th. And then on the right, March 29th, you can see clear damage to that roof in the middle with some of the debris around it. And it was a horrific incident. So Dr. Mwafi and I have also done work using imagery analysis by the UN. UN Satellite Imagery Center has been documenting damage to all structures, all 160,000 plus structures in the Gaza Strip since November 2023, and continues to do so. And so these types of data allow us to look at when a building has been hit, as well as several properties associated with the building that might make it more likely to be hit should shelling, for example, be random. So we use this data to answer questions like, what is the extent of attacks on healthcare facilities, whether or not facilities might be targeted, and if there are any patterns that we can discover. And I'll just highlight the kind of headline results and implications. But so in the besiegement of Mariupol, over 3/4 of facilities sustained damage as visible from satellite imagery. So again, that's probably an underestimate. Healthcare buildings had over 4 times the odds of damage compared to non-healthcare buildings. And the damage wasn't related to how big the building was. So typically in that war, with heavy artillery, it's aimed at the largest buildings. So we would expect there to be a gradient, with larger buildings being more likely to be hit. But because we did not find that association, that does suggest that there was another reason that these facilities were being hit, and potentially it's that they were healthcare facilities. In our work in Gaza, by January, we were able to see a difference in damage to healthcare buildings, with them having over 1.5 times the odds of damage. And so these together really allow us to see these patterns over time, both within a conflict and then across conflicts. So what are the patterns of the combatants, and what kind of impact might this be having on our ability to conduct any kind of research? And then also both immediate operational response, as well as what might be needed for recovery. And I just wanted to add here around communication that I love the responses to Dr. Mwafi's question. And I think that while we usually aren't able to get work out into the peer review world fast enough to have any kind of impact on operational response, it's still important for advancing scientific methods relevant to that type of work. So that's something that we continue to do, but also explore other ways to communicate findings. So this is just a recent blog that we published in PLOS Global Public Health. Dr. Madhu Pai has an excellent list of global public health blogs where you can post kind of interim work just to share. And so this was at the beginning of the escalation of the conflict in Sudan, the escalation in March that our team was working on, and it was a call to action for public health practitioners. So that's it from me. And sorry, and then the implications, I'm running short on time. So just that there are ways that we can use some of this remote data, and as also Dr. Mwafi had pointed you towards humdata.org, which is a great source for data that I think there's a lot we can learn from these settings without necessarily collecting new data. And that using these types of data that aren't direct data collection can help us look at patterns, particularly during a conflict as well as across conflicts, And this can be used both for operational response as well as for accountability later on. So thank you so much. And I'd love to take questions. I didn't see the chat while I was speaking.
Thank you, Danny. I'm gonna just wrap really quickly with two slides because this can be a bit of a bummer as we're discussing these crises, but I wanted to touch on the fact that whenever we're studying these events in real time, but these events are actually symptoms of larger problems that aren't being addressed, right? So those people who look miserable in the photos that we hear that they're getting abused by border guards or human smugglers or who are drowning in the Mediterranean, et cetera, like those people are us, right? I think that's how we as humanitarian practitioners need to, and researchers need to think of them. They are us. They're doctors and nurses, but they're also patients. They're teachers and students. They're business owners, their parents, their children, just like us, right? Their lives just got thrown into turmoil, turned upside down by forces usually outside of their control. And they are people that are seeking health, safety, and security in any way they can, right? And sometimes we catch a photo where they're holding up a sign saying we are human, which seems like it should not need to be said. But I think it's something that should be at the forefront of all of our minds. And we're used to looking at these war zones and seeing the disruption and the destruction. And I think sometimes it's important to just kind of recenter and realize that, like, just a couple of years ago, right, this is Khartoum, the capital of Sudan. Like, it's a beautiful green metropolitan city. Caracas, Venezuela, where we have all these people coming up through the Darien Gap by foot, braving really horrendous conditions. But this is what their country looked like prior to the conflicts there. Lviv, Ukraine is really, I've never been to Ukraine, but honestly, the photos that I've seen, particularly from before the war, are some of the most beautiful images from Europe. And this is a photo I took from my balcony in Gaza City when I was there on an emergency medicine development project, even, shortly before the current war, right? So it's, beautiful Mediterranean coastline. You can imagine the people who live here are not so different than all of us, right? And so when we do this humanitarian health research, it's important to understand that we're doing it to better understand, to better help. And when we push for kind of justice and compassion for the victims of these crises who are suffering usually through no fault of their own, that these are the consequences of what are really collective social, moral, and political failures that kind of involve all of us more broadly. So with that, thank you. I will stop sharing, and I think we still have like 5 minutes for any more questions if people have them.
Feel free
Cheryl,
to
hi, Dash.
unmute and ask, or write it in the chat, and I can also read it.
It's nice to see so many friends, at least listed in the audience. I know some of you might be with earpieces on shift or driving home or driving to work. So I get it if you're not able to talk, but it's lovely seeing your names. If anybody has any questions specifically for Danny, I think some of these remote methods are really exciting new ways of conducting humanitarian health research. I was wondering if you have any experience with community participatory action research in humanitarian crisis from Dr. Snyderman. I personally do not. I have engaged with communities of practitioners, but I have not conducted, actual community participatory research. I don't know, Danny, if you have in any of your prior work.
I would say that the formal definition of community participatory action research is not something that we have done, but that every single project, the research that we do is very responsive to what is the needs that are being presented by people locally. So, and in close collaboration with them, the work wouldn't be possible without that. So I think to that end, it's very much like, from the way that I understand CPAR, is that it's really from the design of the question through carrying out the research, and that is something that we do in all of our research wouldn't be possible without that.
Another question that says research in humanitarian crisis is really important, and I'm curious about provisions made for safety during data collection. Are you able to access safety resources, or are you subject to the same laws that govern civilians? I'm not sure if I understand the question perfectly, but what I can tell you is you 100%, at least I have, any time that I have been in the field, have been 100% subject to the same laws as everybody else, or lack of laws in insecure situations. So it is quite dangerous, and there are no special, there is no like SAEM border guard that is deployed in the field to protect you. So you kind of have to work usually with an operational agency who have their own security protocols. And security is not just, like in a war zone. Like if you were in New Orleans in the United States after Hurricane Katrina, right, when the power is out, the water is cut off in many places, people are looting because they don't have access to food because all the stores are closed or destroyed. Nighttime is kind of an insecure setting, right? And you need to be careful and kind of following different security protocols, making sure that you're able to check in with all of your team members and deciding in advance what is and is not an okay situation to proceed, like with whatever your project. Any more questions? Last one's going.
Thank you, Danny. Thank you, Dr. Moafi. This is Vinay. I'm just driving home from work, but I caught the last bit of this, and it's really great to just hear all the different kinds of research methodologies that you've reviewed and kind of featuring some of the benefits and challenges. So I really appreciate you sharing with our group.
It's good to hear you. Thanks for having us.
Hope it was a good shift.
So much. I'm gonna ask you more questions, but I think since we're already past the time, I'll save it for later. If anyone is interested in getting more involved with our group, we do different webinars that are kind of similar to this. This one I've been working with Dr. Malafi to get organized for a long time because, as you can see, it was really amazing. And so I'm really happy to have you join any of our projects, and I'll put my email in the chat for anyone who's interested.
Well, thank you all. Thank you, Rebecca and Vinay, for inviting us for this, Holly and Dawood for putting together the webinar, and Danny for really outstanding presentation, and hope to see everybody soon.